This episode of Pupil Pod is supported by Dompe.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Lisa Feulner. Dr. Feulner is a cataract, refractive, and aesthetic surgeon in Bel Air, Maryland. Dr. Feulner, thank you again for joining me tonight.
Thank you, Sila. It's an honor to be here and contribute to your amazing project that you're doing.
Let's get right into the case. So this is a 73-year-old woman who presents to your clinic 3 years after cataract surgery in the right eye. She notes that over the last year, she has noticed a slow decline in her vision in that eye. She denies any other ocular conditions, surgeries, and any new traumas. Dr. Feulner, so you have this patient presenting with a change in vision 3 years after cataract surgery. How would you approach this patient? What are some of the things that we need to make sure that we ask or do when we see this patient in our clinics?
So this is a great case, and we see this all the time. I think it's easy to fall into the trap that this woman had cataract surgery in her right eye 3 years ago. But we all know that we have to start very broadly when we think about what might be causing the symptoms that our patients are complaining of. We very nicely have in the history that she had surgery in her right eye and that the problem is in that same eye. We also know that it's been a slow decline. So that's an important piece of information. Knowing whether it's one eye or both eyes, whether it's been a sudden change or a slow decline are very important pieces of information to kind of help guide our minds into what direction we're thinking the problem might be in. Other questions that we want to ask are these symptoms constant or do they fluctuate? We can easily get trapped by thinking or assuming that the patient means that this is a constant problem. And if you ask them, they'll say, well, it only happens after I read or late at night, or they have other times when it happens and they aren't able to distinguish that. And it's our job to pull that out of them. We also need to ask associated symptoms, things like, do you have any flashes or new floaters? Is this vision loss generalized over your whole visual field, or is it in the center of your vision or just part of your vision? Are there any other associated symptoms like foreign body sensations or light sensitivity? So once we've gathered any other symptoms or signs that might help us guide us down that pathway, we can sort of go on to look at other things that might influence the loss of vision in one eye. A history of diabetes would be important, macular degeneration. One of my favorites is ocular surface disease. It's a great masquerader for major, visual changes that people have. Even, after cataract surgery, ocular surface disease can play a big role. Looking at their medication list, things that might contribute to ocular surface disease or other things that could key us into problems that they're having with their vision. A history of glaucoma, of course, is important. And practices that co-manage, we may have lost this patient for the last 3 years and their referring doctor may have started them on a glaucoma medication or may have had some visual field loss that we don't know about. Pseudoexfoliation, of course, is very important, especially after cataract surgery. It can cause, zonular, weakness and dislocation or movement of the lens to cause decreased vision. And you already mentioned there was no history of trauma, but obviously, if we didn't know that, that would be an important thing to ask. Once you've decided that all of those other things don't play an important role in this, going back into your record and figuring out how did you do that surgery? Was it a traditional ultrasound surgery? Was it a femto surgery? So when we put toric lenses in, it's very important because if we have irregular fibrosis of the anterior capsule, we can get a little rotation of that lens and even some tilt in that lens. And for that reason, I personally do femto cataract surgery on all toric lens patients and any other presbyopic IOL patients, because I'm really looking for that uniform fibrosis, that well-centered, well-sized capsulorhexis to prevent things like that. But that's always something we have to think about. Um, in multifocals and extended depth of focus, or a trifocal lens, ocular surface disease, again, is very important to consider as a cause of loss of vision. And if this patient had it in one eye, ocular surface disease is going to play a greater role in that eye if it has one of those types of presbyopic lenses. And again, if it's a toric and a presbyopic lens and they have rotation of the lens or tilt, that's going to have a dramatic effect on their vision through that lens. And then, of course, posterior capsular opacity, which is fairly common after cataract surgery, has to be on our differential diagnosis.
Thank you. I mean, you're really highlighting the importance of thoroughly examining and asking the patient questions, because sometimes we jump right to our conclusion. We have anchoring bias, but in these patients that are unhappy with their vision or coming with a decline in their vision, we need to start broadly and we really need to think about all of the options. So in this patient, on review of their history, you do note that a monofocal IOL was used and that there were no intraoperative or postoperative complications. Her vision was 20/20 uncorrected at her post-op month 1 follow-up, and she has since been lost to follow-up from any eye doctors. Today, her refraction is minus a quarter diopter in both the right eye and the left eye. And despite seeing 20/20 best corrected, she still notes a blurriness in the right eye. On exam, you do notice that there is no PCL, but on careful examination of the posterior capsule and the IOL, you actually begin to notice turbid fluid. Now, Dr. Feulner, I had a patient just like this several years ago as a resident. These are easy to miss cases. At this point, what is your leading diagnosis, and what are some of the things that we need to know about this diagnosis?
So, as you mentioned, you don't see this very often, and sometimes it's more obvious than other times. I think once you've eliminated, you've looked at placido rings, you've looked at the topography, you've refracted the patient, you notice that the posterior capsule is clear, their retina is okay, their optic nerve is okay. You really need to look for this. You need to actively look for this. I think sometimes we dismiss these patients because, hey, your refraction is great, your retina is good, your optic nerve is good, your ocular surface is fantastic. I don't know why you have this problem. And so we sometimes have to look carefully for it. And other times, it's very obvious. And it has several different names. I think the most common name is capsular bag distension syndrome. It's also known as capsular block syndrome and capsular bag hyperdistension capsulorhexis block syndrome, which basically kind of describes what the problem is right there. It occurs in less than 1% of patients, but it can make a huge difference in your relationship with that patient. So if you diagnose this and treat this, instead of just telling the patient there's nothing you can do for them, that can really go a long way in your credibility and your relationship and customer service for that patient. It's characterized by an accumulation of fluid between the posterior chamber lens and the posterior capsule. Sometimes you can see it in the slit lamp, you can see it layered out. It's kind of a turbid fluid that layers out behind the lens. And that fluid causes the posterior capsule to distend. And sometimes it pushes the IOL forward. And this patient may come in with a myopic shift, rarely a hyperopic shift, depending on where that fluid is kind of hitting the edge of that optic. This patient doesn't seem to have that myopic shift. So, really looking for that in this patient, and the layering of that fluid would be really uh, an important step. There was a big study in 2008 that showed that there were some risk factors for the development of this. And we can imagine that people with long eyes, where that lens iris diaphragm is pushed posterior, the bag is often larger than we expect it to be. Um, those people were at higher risk for this problem. Other risks are, they showed that actually in this study, doing a can opener decreased your chance of, having this happen versus continuous curvilinear capsulorhexis. I don't think that would make any of us want to switch back to that. And that, that sealing of the capsulorhexis over the optic all the way around with no gaps can also, be a risk factor for that. I think, we all try to get just a little bit of overlap, not too much overlap, in order to, get a stable covering of the optic. But I don't think that would cause any of us to change how we make our capsulorhexis, but certainly something to look for in the early and the late postoperative periods. It can come at pretty much any time, anywhere from weeks to months after surgery, and in this case, possibly years later. It's been associated with sometimes, intraoperatively it can occur too. And this lady, of course, it didn't happen intraoperatively, but it can occur. And there was a guy that I went to residency with, and we were, in our third year at the VA, and he had done a hydrodissection and blew out the posterior capsule. And I thought, how does that happen? I've never heard of that. And it's been one of these fears that I carried with me because, he was one of my good friends and he's learning how to do cataract surgery and he does hydrodissection and blows out the capsule. Well, this is what happened. He hydrodissected a little aggressively, wanted to get that lens moving. He was, young and inexperienced and blew out the posterior capsule because that fluid got trapped back there. So, I think, as far as that goes, when you're an early surgeon, learning how to burp that fluid forward as you do your hydrodissection can prevent that from happening.
It's so great to hear your personal anecdotes because I feel like that was one of my first fears when I was learning cataract surgery because everyone swore that was something that could happen. Thankfully, we don't see it as much anymore because we're all told from day one, be very careful during hydrodissection or you'll blow the bag, but definitely something to keep in mind. So, with this patient, how would you approach treatment for them? Are there any differences if this were early postoperative versus late postoperative capsular distension syndrome?
Yeah, so this is an interesting one. Her capsule is clear. That's the dilemma. So if she had capsular opacity, it would be very simple, right? We just do her YAG laser capsulotomy, and that all of that fluid's going to go into the vitreous, and she's going to see well again. Anytime you have a clear capsule, you kind of have to wonder, is this the best choice? Personally, I probably would have still done it in this case, but there are alternatives. If you can create a little space in the anterior capsule, depending on how much overlap you have, you can create a pathway forward for that fluid if you want to preserve the posterior capsule. So you can do a YAG laser to the edge of the capsule in one area and create a pathway forward. Now, one of the problems with that method is now you can potentially have cellular material or inflammatory contents in the anterior chamber, which you might have to deal with a topical anti-inflammatory, or it may cause some increased pressure if you have some of that debris clogging your trabecular meshwork, causing an IOP rise. So sometimes if you're going to do that, you might want to keep that patient there, check to see if they have like a little post-op spike, and just empirically treat them with a mild steroid, a lotoprednol or something like that for about a week. When that comes, that dilemma presents itself and you're trying to decide with a clear capsule. I'm always very reserved about doing capsulotomies in diabetics. We know really consistent data over history shows that once you open that posterior capsule, you increase the chance of a worsening of diabetic retinopathy, or and I think in a case like that, I would probably try to vent it forward if that capsule is clear. If they have a lot of retinal pathology, multiple retinal surgeries. Keeping that barrier between the anterior part of the eye and the posterior part of the eye is really important for preventing problems with like CME or, decreasing your chance of retinal detachment in a very long eye. So you kind of have to think, about the whole eye and the patient's whole health when you decide, do you want to do a YAG posterior capsulotomy or do you want to try and vent it anteriorly? And, after 3 years, there's some pretty good fibrosis there. So I'm not really worried too much about making a little incision with the YAG of the anterior capsule if I can accomplish that in a high risk patient.
This episode of Pupil Pod is supported by Dompe.
That's a really excellent pearl, and I think one that we don't necessarily always think of. We generally go straight for the posterior capsule, but in cases like this, that seems like something that could really benefit certain patients.
Yeah, I think that it's a lesson in looking at the whole patient and not again getting trapped in our knee jerk reaction to something that we're used to. It's just taking that moment pause to decide. I have a couple choices. Let me look at the patient as a whole and figure out what's in their best interest, what's not necessarily easier and simpler for me.
Absolutely, absolutely. All very, very important points. So, I mean, these are such rare cases. And now, hopefully, our listeners, myself, will remember that this is a possibility to look for it and that we might need to treat this a little bit different than we would normally think. But what about the most common capsular complication after cataract surgery? So there's one that we all know like the back of our hand, but can we go through that in a little bit more detail? Can you tell us a little bit about that?
Yeah, so unlike capsular block syndrome, posterior capsular opacity is probably the most common postoperative reason that patients come in complaining of decreased vision. The AAO released a study in 2023 that showed that anywhere from 20 to 50% of patients within 2 to 5 years of cataract surgery develop PCO. I think those numbers are probably a little bit skewed, but maybe not. I think that our new methodologies of cataract surgery, more advanced type lenses and structures of lenses may shift that number, but it's super common. And, it's so common that we tell our patients that before we do their surgery, that this is most likely going to happen at some point anywhere from months to years after surgery. Some of the risks for this are related to the age of the patient. So younger patients, they're more inflammatory anyway. They heal faster. They're at higher risk. Again, patients with longer eyes, longer eyed people are higher risk for a lot of things. Diabetes also put people at risk for many things, including PCO. And, a hard lens, that had a lot of adhesion to the capsule, had a lot of conversion from the cortex to the nuclear component of their lens, they're at higher risk for capsular opacity. Anytime you have retinal surgery or injections for wet macular degeneration, anything that irritates that capsule is more likely to cause posterior capsular opacity. And certainly we know that uveitis, chronic steroids, not only causes cataracts, but it also increases the chance of developing posterior capsular opacity. And over the years, it's been studied widely that the shape of the edge of the lens plays a big role with a square versus a curved edge of the implant. It's thought that the square edge kind of blocks that those lenticular cells that remain behind from migrating behind the lens onto the capsule. I don't think it's 100%. I have used plenty of square edged lenses that still get PCO. I think it's extremely important to do capsular polish. I do both manual and IA polish of the posterior capsule. So I do an IA polish first, and I include the anterior leaflets that remain to remove any kind of cells that are on there. And then sometimes you get this posterior capsular adhesions that you just can't get off with the IA polish. And so I use a catheter with a very small silicone tip on the end of a syringe. And I kind of can scrape along the posterior capsule to release some of those stringy cortical pieces or any other kind of adhesions while I'm irrigating BSS. And I find that if I do a combination of that, it doesn't take very long. It might take you, 10 seconds more or 15 seconds more to do that. But I do find that the cleaner you make the capsule, the longer patients have with a clear capsule before they develop posterior capsular opacities. I used to make, so in my career, I started out with making really small capsular excess because I was afraid it was going to run out, right? I was terrified that I would lose sight of it under the iris. I couldn't bring it back. And what it made me is really good at doing small pupil cataract surgery because I created these tiny capsular excess. And I had to get all those pieces out through that little tiny hole. And I created a lot of other things, like phimosis and things like that. And then I said, okay, well, now I'm going to make them really big because there's all these different methods where you can tilt and tumble, bring the lens into the anterior chamber. And then I realized that, the optic wasn't covered and my refractive stability was not as good. And so now I really try to make a 5 millimeter, for the most part, capsular excess. And I try to just have an even overlap around the lens edge to stabilize and centrate the lens, but also in hopes of protecting any migration of lenticular cells around to the posterior capsule. So I think capsular excess is an important component in addition to polishing the capsule, as well as your choice of material. The studies have actually shown that PMMA is the best one to prevent posterior capsular opacity. If I look back at some of the old timers in my practice that have old PMMA lenses, and I have to say they're few and far between at this point, they can go forever. Like my dad had a PMMA lens and his whole life he never developed PCO. And so I think, we're not going to go back that way, but next probably is the hydrophobic acrylic lenses are probably the least likely to cause posterior capsular opacity. Silicone lenses, hydrophilic lenses are all more likely to develop PCO. So, I think when we're making our surgical plan, all of these things are really important to help us reduce the incidence of posterior capsular opacity, or hopefully extend the period of time between when we do surgery and when they need a laser.
And how do you treat these patients? Can you tell us a little bit more about the laser capsulotomy, maybe your settings, what you do in your practice, some of the risks involved?
So, I always have this conversation with the patients, and I think that's your first step, is setting the expectations to the patients, because the one thing that you have to communicate is you don't need a pre-op physical, you don't need any pre-op medicines, there's no post-op restrictions, and there's no post-op medications. And we do it right here in the surgery center or in my office. Then you get a smile. And then I explained to them, just like I did today, I dilate your eye. I put you in the same kind of machine that you just were in with a laser on the other side. I show them the lens that I used to look at the fundus, and I say, and we're going to use a lens just like this to hold your eyelids open. And that's important because they're always afraid they're going to blink. So I always tell them, don't worry about it. I'm going to use a lens that's going to hold your lids open. We're going to focus that laser on the back of behind your lens, on that cloudy capsule, on that scar tissue. We're going to pop a little painless hole in it. Takes less than a minute, and off you go. Your vision's going to get better, as soon as your pupil goes back to its normal size. I explained to them that there are, several risks to the surgery, but that they're not very common. The most serious is also, very rare, and that would be a retinal tear or retinal detachment. And I remind them that the risk after laser capsulotomy is lower than after the cataract surgery itself. And I think that's a really important thing to tell patients. I used to have a conversation about, the lens moving, dislocation of the lens. And we mostly saw that with plate lenses and silicone lenses. They were kind of slipperier, they could slide around in the capsule. And we don't really see that now with the lenses that we have, the single piece lenses. But, you could have that discussion with them. Of course, if they're diabetic, you're going to have to explain to them that there is a potential for worsening diabetic retinopathy. I think CME is not something I see commonly unless the patient has had multiple surgeries, multiple retinal surgeries, diabetes, lots of other things that would put them at risk for it. And again, you have to look at the patient as a whole and really address some of the risks that are particularly associated with that patient. I don't tell every patient that they have a risk of CME because I just don't see it except in patients who are predisposed because of other retinal issues, chronic uveitis or something like that. Um, Rarely these patients can get some inflammation. So a lot of times, or I wouldn't say a lot of times, sometimes they have a lot of material in that capsular opacity. And when you laser it, you can see it released into the vitreous. It kind of makes this big cloud of white stuff. And those people, I put on a load of prednisone just empirically 4 times a day for a week, just to treat anything that might come of that. I think you always have to worry if you see something unusual, and there have been some things that have been unusual. One of the things that people always ask is, can this happen again? Can I get this? Well, I need this laser again. And I would have said no. I have had some patients who years after capsulotomy have come in with decreased vision. And on examination, they have sort of a membrane that has grown over and around the opening of their capsulotomies. And sometimes we think this looks like an endophthalmitis or P. acnes or something like that. I actually had one patient where I couldn't figure out what it was, put him on steroids, did all these things, sent him for a vitreous tap, and still nothing grew. We didn't know what it was, sent him back to the retina specialist. He actually did a biopsy of the membrane and the capsular flaps that were back there, and turned out that asteroid hyalosis can cause this sort of inflammatory membrane and precipitation on the capsular flaps and cause a loss of vision after capsulotomy. It's not very common, but it is something. So when patients ask me, I don't say never. Now I say extremely rarely. So those are some of the things to think about when you're talking to patients about their laser.
I mean, I would have also said the same, but I think once you do, what do they say? What's the quote? When you do something long enough, you see everything, or there's nothing you haven't seen. So this is just such a high yield episode. And I feel like we went through some content that every single person that listens to this episode will be able to refer back to and remember in their clinics, because these are the patients that we take care of every single day.
Absolutely.
Dr. Feulner, before we end the episode, I ask all of my guests, if you could have dinner with one person from any time or place in the history of humanity, who would it be?
That is such a tough question. For me, female role models are always, number one on my list. And I have to say, my mom, who passed away 10 years ago, would have been my number one, but she would take a whole podcast to explain in and of itself. So I won't dwell on her, but there is a person who I learned about recently, and her name is Yursa Mardini. And she's a Syrian refugee who I only learned about her because I watched a movie on Netflix called The Swimmers. And she fled with her sister in 2015 from Syria. And her whole dream, her whole life was to be an Olympic swimmer for Syria. And her father's dream was for her to be an Olympic swimmer. And she fled with her sister. And the story of what these young people went through and what they suffered. And she swam 3 hours across the Aegean Sea, and pulled a boat full of other people with her sister to safety, and traveled on foot through Europe and did all of these things and ended up in a refugee camp. And even once she was there, her only goal was to get back in the pool and swim and be an Olympic swimmer. And in fact, in 2016, she was in the Rio Olympics under, a refugee team, and was in a second Olympics, and is just really an amazing woman. With her sister, they fight for awareness of what refugees around the world are going through. And like, I think I'm a strong person, and I'm smart and talented, but I've been given a pathway to my life, and I'm not going to say I didn't fight for anything. I did. I fought the whole way. I worked really hard. But to be able to sit with somebody who's had a single-minded goal that defied all odds and achieved that goal against all odds, and now uses her story to help other people in the world. I just think she's magnificent. Like, I would love to meet her.
What a truly beautiful story. I think I had heard about it, but I didn't know the depth. And it's just so amazing that you chose her, first of all, especially you being the strong female role model that you are to young ophthalmologists, but also just to highlight the resilience and dedication that women have if given the opportunity and the ability to succeed against all odds. It's really just so, so beautiful.
And she comes from a country where women are really repressed. So in so many ways she was repressed, and so many people would have given up, and she never gave up to the very end, to the very end. And if you haven't seen the movie or read about her, I really believe that her story gives us all such a perspective, and a healthy perspective, and gives us all wisdom on how we want to live our lives and how we perceive situations and struggles and battles. It really just gives a whole different perspective. And I think everyone can learn something from her.
That's so beautiful. I'm definitely going to check that out. And it's just always so important for us to not only recognize our own privilege, like you said, but also to always remember that there's just so much that each person is just such a complex organism with so much to give and so much to offer in terms of wisdom to those around them. So Dr. Feulner, thank you so much for joining us on this episode of the Pupil Pod. I certainly learned a lot. I know that our audience will learn a lot listening to this episode.
Thank you for having me. It's a real pleasure. And I love what you're doing. And I applaud you for your efforts to share knowledge broadly with your peers.
Thank you. And thank you to those tuning in. See you next time on the Pupil Pod.